Thank you very much, Atul. Good morning to everybody. And thank you for welcoming me, Christine, Nawel, and others. It's always a pleasure to be with the Patients Association. I wasn't prepared. I wasn't prepared to get challenged the way I've been by our colleagues and friends from Northern Europe, all these canals, blooming flowers, beautiful cities, sunny weather. So I quickly gathered a couple of slides. I felt, obliged. I had to defend. I said, I'm also living in a nice place. We started as a village some time ago. The first king then was Christianized by Remy, Bishop of Reims. And we tried to make some constructions in that time. Cathedral, the Louvre, the Sorbonne, first university. So please come, you're very welcome. Maybe after Birmingham, but in 2 years, okay? Look, take your lover, take your girlfriend, yeah. That's our fish and chips. Okay, and this is the place where I really live, with the castle and our university. But believe me, the hospital doesn't look really like that, so you can always arrange things with pictures. Okay, that's one. And second, I just prepared when I got the invitation from Christine and Nawel, a case report, but I've seen how exhaustive and complete the presentation of colleagues were, so I tried to be maybe a little bit more complete, and we'll talk about genetics also. Okay? We'll start with very basic and educational slides. This is only for those of you who are not so familiar, maybe even to raise a hand and ask me questions. So that's specifically dedicated for patients, okay? This is a typical pedigree. So you may or may not know that we use square to represent males, so they are boys or men, okay? We stain them dark or black when the patient is affected and leave them white when they are healthy, okay? So circle will be ladies or girls. So just to remind you that you saw how important it is to do a proper family investigation in order not to miss and diagnose patients. So we have some very simple rules in genetics to maybe anticipate or predict who can or cannot be affected, when you just look at the pedigree. So this is a typical mating of one male who is affected with Fabry disease, and he meets a girl or lady who is not affected, is completely healthy, We human beings, we have 46 chromosomes, but we have 44 non-sexual chromosomes and 2 sexual chromosomes. This is the key difference between males and females, okay? So in the male gender, we have only one X and the little Y chromosome. Females, in contrast, have no Y, but 2 X chromosomes. That will explain you the basics of phenotypic difference which can initially be observed in Fabry disease, even as we learn, that can also be balanced and mitigated. So why is this? Because the gene for Fabry disease, it is located on the X chromosome. Could have been anywhere else, on chromosome number 1, 2, 3, 7, 19, whatever. It's not the case, it's on the X. So in the case of this male patient, he has his mutant GLA gene, that's a gene coding for Fabry, which is either completely destroyed or hampered or mutated, okay? And in front of absolutely nothing to compensate. The Y chromosome does not have the role to compensate for alpha-gal activity, okay? So this is a dramatically decreased enzyme activity. In contrast, so the little star is for Fabry disease, okay? That will track in the pedigree where is the disease. So, how can I cancel this here? Let's look at what will happen. Did I miss something? No, okay. What will happen in this kind of mating? So, you have this male patient, this healthy lady, and they will have the 4 offspring. When you make a baby boy, the gender will be determined by the fact that the father passes his Y chromosome. Okay, so first son, he will pass the Y because for this baby to be a boy, he has to receive the Y from the father, okay? Then the lady pass one X. This is normal boy, okay? Second situation, exactly the same, you know. The Y is passed by the father and the second X say from the mother. So again, healthy. So this is the first lesson, you know. Whatever the number of boys that this kind of couple will have, you know, there will be no affected boy, you know. Father to son transmission in Fabry disease is just impossible. Okay, this is a key rule of X-linked genetic disease. Now, same situation, but they are now making baby girls. So that means that the father will pass his X chromosome. This X chromosome is mutated at the site of the GLA genes. It can be absolutely perfectly normal in anywhere else, you know, along the chromosome. It's passed to this first daughter who received the first X from the mother. She's a heterozygote, okay? So one mutant X, the second X, which is normal in terms of Fabry disease and confers some kind of protection, you know, more or less. And the same situation will be true for her sister, you know, who has also received this X mutant from the father, second X, and she will be a heterozygote or carrier, or we can say patient nowadays, okay? So in contrast, all daughters of an affected male, with all biological daughters, you know, will be heterozygotes, okay? Second lesson. We, in genetics, always have to consider false paternities. That does exist, you know, not only for Fabry disease, but it's a global knowledge, 8 to 10% of children, so, you know, don't go too quickly. Yeah, 8 of 10. 8 to 10. Oh, sorry, 8 to 10, yeah, my poor English, yeah. No. Also, you know, in some countries maybe. Second circumstance we may come across, it's completely different. So we are now talking about a healthy guy who meets a heterozygote lady, okay? So he is X, normal X, Y, and she has a mutant X for Fabry and the normal one, you know? And now you can have, it's completely different situation. You can have 4 types of children. First circumstance, dad passed the Y chromosome. So this will be a boy. This boy received the mutant X from his mother. So mutant X, nothing in front to compensate for enzyme activity, full-blown Fabry disease in a male fetus and then son, okay? Second circumstance, another boy. So he has received the Y from his dad, and this time he has received the healthy X from the mother. So this kind of couples, they can perfectly have, you know, also a healthy son. And this is something that we have to explain during the genetics counseling, which we very often do. Now, the girls, this one, she has received the normal X from her father. If she would not have received an X, she would be a boy. But so she's a daughter, so she has received the X. And this one has received the mutant X from her mother. So she has the same condition as her mother, but there is clinical variability, you know, because she has the same genotype when it comes to Fabry disease than her mother, but the other 22 or 23,000 additional genes will be, you know, more balanced or different, you know, partly different. And finally, the last daughter, she has inherited the normal X from dad, the normal X from mom. She's completely healthy, and it's forever, you know. Even in her offspring, the disease will not reoccur. Okay, so I think this is something that has to be very clear, I hope, in your mind. Okay, and now I would like you to play a little bit with me to start with, and then I will give you some additional explanation on how sometimes case can be tricky when it comes to medical genetics. This one is easy, although at the time that was one of my first Fabry cases, something like 15 years ago. I was much younger, much more naive, and so this is a story of Regis, here. He was 19. pain, acroparesthesia. We sequenced the gene and we found this G373D mutation. Who would you have tested immediately after having made the diagnosis of Regis?
Everyone except for the mother and all of the children.
The mother and all of the children? Same time, Jerry?
No. Well, yes, you know the mother well, unless there's something funny going on. Well, it has to be the mother has it. And then, so if you already, once you know the family mutation by testing the mother, then the analysis of the rest becomes easy. Correct? A different process. The enzyme assay on the boys, and you don't even really, I guess in some countries, if you need verification of a test, you would have to do DNA analysis on the girls also. But if you don't need verification for some sort of insurance, then you could just assume they have Fabry. No, I'm sorry, not assume they have Fabry. You have to test them.
I think actually Jerry gave us his answer. He said, if you want to know the family mutation, you test the mum. He said that.
Yeah.
Can we take that as your answer, Jerry? Because your question was, who would you test next?
Absolutely. Because Jerry's gave us many answers, indeed. So that.
I'm thinking through it as I'm talking.
Yeah, I could see it. Any additional idea? Well, if we focus on this answer, that's congratulations, Jerry, brilliant. And I was not as good as you are at the time because we were starting with enzyme replacement. So I was very eager, look at this potential family. So I went directly to the brother, negative. No Fabry, well, good for him, okay? Second brother, negative. Sister, no mutation. Second sister, new mutation. Third sister, new mutation. And then finally, I should have, followed your advice. I went to the mother, and she was also negative, So this is rare, less than 10% of the case. But de novo mutation, they do exist. Genetics disease have to start at one given generation. It's most of the time inherited through families, but not always.
Dominique, it feels me that the mother would be negative. But a brother could be affected because of mosaic.
That guy is too quick, too clever. So, okay. Do it. So, precisely, Gabor facilitates me. It's also one family who is in Paris, Versailles, and I have these two boys, they have Fabry disease. And so, can we say that their mother is an obligate carrier? Can we prove it? I mean, can we affirm it, for sure?
You mean through testing?
No, like that. Okay. Good point. So, I am in a hurry, I made the diagnosis, clinical diagnosis, and confirm with molecular testing of these two boys, so they have a mutation in the GLA genes. And I don't know, enzyme is available, but we may run out of it, so I have to speed up the treatment of this lady. Am I allowed to put her on enzyme replacement at this stage? You would say yes. This is the only information I have access to.
Well, so I think you're saying it's not a new mutation because two of the sons have it.
No, sorry. There is a little mistake on my slide. I should correct it. Sorry. Don't take this information. Let's erase the little dot inside this circle. Okay. Let's keep her like this. So we know those two, they have Fabry disease. This is the only confirmed information that we have. Are we allowed to treat the mother?
Well, is there a remote possibility that two children could both have a de novo presentation? Probably in theory, yes. In practice, really, really, really remote.
If you say this, would they have the same or different mutations?
So they have different mutations. There's something that
Okay.
definitely going on.
how did you say, remote? That's more than remote, because if we consider classical Fabry accepted figures in the literature, 1 in 40,000, even if it's completely, thought again now, you have to multiply those. So that's 1 on 40,000 multiplied by 1 on 40,000. You can hardly imagine this. No, it's not a possibility. It's okay. So, but if they have the same mutation and same, you cannot imagine that precisely the gene is hit at the same location by 2 independent events. That's statistically speaking, it's impossible. So it's a little bit complicated to think in that case. I would say that, as you say, there is a likelihood more than, say, 95, 97, maybe 99% that yes, she's an obligate carrier. This likelihood would be 100% if she would be both the mother and the sister of a patient, or if she would be the daughter of an affected guy and the mother. In that case, I would treat her, if I would need it, without going necessarily to the lab and confirm, okay? But in that very specific pattern, there is a little 1 or 2% which it might not be true. And we face what is known as germinal mosaicism. That means that this lady is phenotypically normal. I mean, in her somatic cells, she doesn't have Fabry disease, and only in the ovocytes, there was not only one, but several ovocytes, and 2 of them were used to make those 2 affected babies. Okay, so in Paris we had this kind of thing. So I could not go further because they were boys. They cannot have received the mutations from the father. But there is a publication from our Czech colleague where they had this circumstance. So 2 baby girls definitely proven to be mutated for GLA gene. And since that could have been the mother, okay, so how can you go further with the ovary? It's basically impossible. But that could have been the father, so they investigate the sperm. And indeed, while those 2 individuals were tested negative in the blood, okay, the father was bearing Fabry mutation in the sperm, but not only 1 spermatozoid, but several, okay? And so 2 mutated spermatozoids were used to give 2 affected boys, despite father was actually phenotypically normal. Okay? No.
Professor Germain, back to your first question.
Yeah, sorry. Yeah.
In the beginning, you said, would you give her ERT? So your answer really is, yes, she is a candidate for ERT, but because she's a female, you'd have to base it on symptoms anyway, not the fact that she's...
No, that's a different discussion. The only point is I just wanted to emphasize that if you would be in a hurry, actually, we face that in real life, because at one point we embark on treating females and even for a clinical trial, and there was some kind of a bottleneck, it's a long time ago, to get access to genotype results in the lab. And what I mean is, if you would have again the father or the brother, you cannot have any missing link. So that lady would be an obligate carrier. This is the definition. Both daughter and mother of affected boy, or sister and mother of affected boy, okay? But only being the mother of 2 affected boys, there is a likely possibility that she is an obligate carrier. That's the word, okay? But again, except if germinal mosaicism. Okay? Well, I can comment after, also during lunch. Pedigree number 3, the importance of drawing things and of medical genetics. Olivier, 27 years of age, I'm always telling the story, nurse in our nephrology department, you will never believe me, yeah? A nurse in our nephrology department, no pain in the extremities, never. no skin symptoms. So we made the diagnosis was made when, by chance, an evening he went on duty, and he unfortunately experienced a stroke on his cerebellum, and then the diagnosis was made. So of course, I investigate. He told me about his mother and his brother. I went to the brother, tested and found his knees. They are all affected, and so we treated at least the two boys. And I was not good enough. So, I stayed at this stage for at least, we lost 5 years, but also the patient on that case, they were not really helpful. And after 5 years, all of a sudden, they came to me and they tell me, hey, doctor, do you know, we have a cousin who is about to go on dialysis in Lorraine, another part of France. And I said, what? What is the story? You never mentioned that. Oh, no, our mother and her sister, they had very bad relationship, so we didn't speak to each other. And now things have warmed up, so, we see. So now I'm delivering you the information. Gosh. So I called my colleague, and we found that guy, okay? And of course, then we were informed about other possibilities. And, that's also the sister, the nephew, and this has benefited the most. Because Olivier, again, at the time was 27, 30. But I got that guy at something like 25, put him on Fabrazyme, and now, after 10, 12 years, he's doing perfectly fine. So, okay, the importance of going in depth into pedigrees. Okay. Screening. Many colleagues touched about screening this morning. We also tried to do one in France that was focused on the heart, so we basically mimicked what others had done before us. So we use the dry blood spot, and we focus on patients with at least 15 millimeter thickened septum in the heart who were attending cardiology clinic, very often without any clinical diagnosis, sometimes since 10 years, and we just did a very basic test that's assaying the alpha-gal enzyme activity on the dry blood spot. We tested 300 male patients, and we ended up, indeed, with 4 of them, so that's basically 1.5%, and I think it's a now commonly accepted figure, who were affected, so with Fabry disease. And again, some of them had been attending cardiology clinic for up to 10 years. 3 of them had benefited from a pacemaker, but again, without diagnosis. And of course, this is a genetic disease, so having diagnosed those 4 allowed us to open, the window to their different families, and additional relatives benefited from enzyme. Some additional thing is you can use the paper to also do some genotyping if you're really in a hurry. I mean, it's not spectacular in terms of results, but it can help you a little bit. So one patient was treated, and you also commented a lot about, difference on preparation. But so he was initially put on Fabrazyme. I missed one histogram here because the decrease was more important, and we had to switch. And I was interested to see the increase in urinary GB3 after the switch from Fabrazyme to Replagal. We have reverse switch now, and okay, next year I will show you where is it? Is it up or is it down again? Okay. To make a long story short, the guy, one of the 4 identified patients, okay, came from Portugal. So there is a lot of work in the plate of my dear friend João Paulo, but we had 2 brothers in France. So this one was diagnosed through the screening protocol. So I showed you the sequencing, and so interestingly, you see, we had 15% residual enzyme activity. So it really fits the picture. I mean, it was discovered, he was diagnosed through the screening protocol, he had some kind of residual enzyme activity, and we found this mutation here, F113L, which is known in the literature to be a cardiac variant mutation. Okay. Now, finally, he tells me about his young brother in France, Manuel. Manuel doesn't want to come to the site. He resists for 2-3 years. Finally, he's kind enough to send a blood sample, and I do the enzyme activity, and I find this very surprising, 45% residual enzyme activity. It's very surprising to me because in our hands, I never saw that. So we have the high part of the results. From 70% to 100%, you are normal, you don't have the disease, you know. When you find a very low result, 0 to 5%, you have classical Fabry disease. We are able to pick up cardiac variant from, say, 5 to 25% of Fabry disease. But in my experience, there is a no man's land enzyme activity from, say, 25, 30 to 70. I never find any individuals there, okay? So why this 45%? So I asked one of my assistants to go to genotyping, and this is the result that she got, you know? So I briefly considered about sacking her, you know, from the lab and the division because, you know, 2 different mutations in 2 different brothers, and she even made a hypothesis, so has the mutation got some conversion? This is nonsense, you know. So this is where it's useful to know a little bit the literature on the disease when you want to work on it. And I went back to this interesting screening program done in Portugal. Colleagues also looked for the presence of Fabry disease among a cohort of individuals with stroke. And even if at one meeting I gave an award to this study, you know, I've always been a little bit skeptical about the results. And when you go into details, indeed, you look that they found a number of patients that they said affected with Fabry disease, you know, but a little bit too many for me. And look into details. You know, they found this D313Y, very question polymorphism in my mind, you know, we can open the discussion, and they also find the R118C. So the only possible explanation is that actually the grandmother, the mother of those 2, you know, was actually a compound heterozygote for a real cardiac variant mutation, which she passed on her affected son, who developed the cardiac variant of Fabry disease at the age of 50, 55, 60, you know, hypertrophic cardiomyopathy. And the second one only received the common Portuguese or Iberian polymorphism, you know. And if you're kind, next year I will tell you the end of the story, because we got him last week in the division, and I can tell you that we have screened absolutely everything in order to determine if yes or no he is affected with some kind of mild case of Fabry disease or is absolutely, you know, virgin of any symptom or involvement. Do you give me permission for last case or no? Okay, so final story. That's all about women. So female, 27 again, angiokeratoma, neuropathic pain. She's a member of a beloved family I'm taking care about since now more than 10 years. Interestingly, she has a very severely affected sister. So this is a pedigree, and I don't know who, Jack mentioned 5 generations. We were able, that's an interesting story. That was also the beginning of enzyme replacement, and we received 2 samples, you know, with 2 different family names. I looked at the gene, Fabry gene, and I found the same mutation, but they're different names. So I called the local colleague, and I tell him, well, you're doing very well because I'm trying to take care of Fabry patients for France globally, And at the time, I had only, say, 10, 15 families. And you, in a limited area, you have 2 families. And he said, but I don't have 2, I have 3 families. And he sent me sample with an additional third name, okay? We looked for the mutation, and of course we find exactly the same mutation. So the guy went to the churches and the records, and he was able to draw the pedigree on 9th generation. So we went back to 16 something, you know. So this is only one piece of this huge pedigree. She's a lady, as I mentioned. Look at this wonderful example of false paternity. So I did not comment it too much for the unaffected sister. So let's just concentrate on those 3. She's only 27, but she's severely affected. Look, enlarged, heavy mass, already many cardiac symptoms. The GFR, measured GFR, 37. So very severe, very aggressive Fabry disease in a young lady. I went to the biology and no residual enzyme activity. Okay, the classic mutation found in the family. I did the whole screening of the gene, nothing else. Okay, so what is this? So we are here very, very low. Okay, so is this one more complicated female cases? What should I do? What do you suggest? Have we done our job? Yes or no? Well, I think we did a good job. We investigate the lady from the clinical point of view. We did the genotyping. We even went to enzyme activity to get a feeling of what's going on. So basically, I think that was okay. And I think we would have normally been entitled to stop there. But then I was, if I can say so, I was lucky because she helped me. She came back and complained that after 2 years of attempts, they could not get any baby, So for geneticists, that's a reason to go to karyotyping, okay? And we did the karyotyping, and so the formula was not normal. So I told you we have to have 46 chromosome. She's a lady, so I want 46 XX. So I had 46X, one was normal, but the second one was funny. That was a funny X chromosome. So it was almost normal, but he had received a little piece of the Y chromosome. So I started to think to myself, hey, so she has received some kind of mixture, recombination of the X chromosome from her father with a little tip of the Y. It's complicated. So this is here, you can see it's a little bit longer, it receives something. So you may or may not know that on the Y chromosome is basically one important gene to give us masculinity. It's named SRY, and it's classic in that circumstance to go and look for it. And indeed, she had received the SRY. So look, the green is showing the X chromosome, and she has received the masculinity marker. So at that stage, I did not understand anything. I went back to the bed, I made careful examination. Yes, she was a female, for sure, having the male gene, the gene giving normally masculinity. Okay? So maybe the gene could be mutated. And that's why she remains a female. So we sequence SRY. But no, SRY is completely normal. So it could not be a mutation that explained this. And then, new genetic technique, CGH, comparative genomic hybridization. What you do is you mix up the DNA of your patient with a control DNA, same gender, okay? And the only information it gives you is either there is too much genetic material or too few. Microduplication, microdeletion, okay? And indeed, look at this, the green part, there is a hole in her X chromosome, in the funny chromosome. There is a missing piece with a number of genes. I don't know how many, 10, 15, 20, 25 genes missing. Okay, so this was a very important piece of information. She had a normal X chromosome by Gabor. She had a derivative, so funny, with an additional problem, which is a deletion taking off many genes on this X chromosome. And this is where comes this very important concept of X inactivation that may explain to you why we observe so many differences in females, phenotype. Females individuals in the human species, they have again 2 X chromosomes. Males, we only have 1. To a medical geneticist, it's immediately a problem, because if you consider little babies with trisomy 21, what's their problem? They have 3 21 chromosomes instead of 2. And as you know, it's not very good, mental retardation, okay. So for us, human being, missing a gene is not a good point, but having too much gene dosage is also not a good point, So why are females doing good with 2X when we males have only 1, So either one of us should have some problem. So nature has developed something which is a systematic inactivation of one of the 2X chromosome in every female cell. So one of the 2X chromosome goes silent. It will sleep for the whole life, So it goes to the nuclear membrane and is inactivated, silent. And only the other one is active and expressed. So that brings you the dosage exactly as the same as male, okay? This is a statistic concept. So you expect to have 50% of ladies, the X you have received from your father to sleep, and the 50% from your mother to also be inactivated, okay? So in many, many cases, you will have a 50-50, 60-40, 70-30 is acceptable. The difference is when you are at the margin of this bell curve, So here, if we consider blue to be normal, those Fabry ladies, they will be absolutely healthy. In contrast, at the opposite of the spectrum, they will look very much like the male counterparts. Okay? This is named as X inactivation. This is random X inactivation. This is skewed X inactivation. Skewed in the wrong way, skewed in the good way. So, in other words, look, this is... Maybe you get a bit of feel with this. Expected situation, if we consider this to be healthy, perfectly healthy female tissue, completely affected female tissue. That translates, I owe this slide to Deraline, and look how beautiful it is. That's a staining of different female tissue biopsies. And if you consider, for instance, dark staining to be normal, this is a part of a healthy tissue. This is completely sick, affected. Same here. This will be disease. This will be healthy. This will be disease. This will be healthy, So this is a patchwork in that case, but you may imagine this to be, again, completely skewed. So I think that back to Our Lady, we have a possibility to test this. And my hypothesis, when I saw the deletion taking off 20-25% of important gene, was that it drove the X inactivation mechanism to be skewed. And actually I was right, so we can do this in the lab. Initially you have the 2X chromosome of the lady, and you do something special, and then only one of her X chromosome was fully expressed, but always the same. We were expecting two similar peaks. So maybe I go a little bit quickly. This is standard before doing the experiment in the lab. Then you have 3 possible results. Either you keep exactly this figure here, that means random inactivation, random distribution between the 2X. You may have a little bit skewed, acceptable, and you may have completely skewed. This is completely skewed, This peak has disappeared. So only one X was always expressed in our patient. The second one is permanently silence. And actually, so she permanently silenced the very complicated X derivative, and the other one was always fully expressed, but actually the other one was inherited from her father and was bearing the Fabry disease mutation. Okay. Okay, and I will skip this. That is what is on my plate. Well, I can make it to you how complicated, our specialty. So she's here, and now if she comes back to the clinic and would like to seek advice from future baby, look at the difficulty. So if she finds a healthy boyfriend or husband, if she passes mutant X for Fabry, Y from the father is affected baby boy. Second situation, the father passes the Y and she gives the funny thing, that's even the worst case scenario because I don't know the result. With all this missing gene and so on, we could have mental retardation, we could have malformations, that's very complicated. Here, she would receive the X from the father, she would be a female heterozygote for Fabry, and this one would be similar to the lady who is our patient. I forgot to tell you that we went to the first generation, and her mother is actually bearing exactly, of course, the same modified X chromosome. So that was an extremely difficult families, but I withdrew some other pedigrees. Witzke knew some of them, but that's unbelievable how sometimes it can be complicated. And in these times of economical crisis, I'm fighting with hospital director for the budget, and we are prevented to go further. I think we could make some mistakes, sometimes not going enough into details. I hope I've convinced you. Thank you very much.
Thank you very much. So we read in literature that it says that the variable symptoms in females is, I've read it many times, it says at least in part due to skewed X inactivation. And so is that part of the other answer, is that it takes, sometimes we're missing other genes, that a combination of different polymorphisms is the other side of why females have variable symptoms. It's not, I think what I've read is it's not just skewed X inactivation, other factors also.
Yeah, I cannot answer Jerry today. The literature is extremely poor. Basically 3 papers, 1 anecdotal, so only 2. Dramatically opposed results. So one is saying, yes, X inactivation is important. The other one coming from Giona Altarescu, who is a brilliant geneticist in Israel, says no clue. She did a proper study and exclude the key importance. So I guess importance is not denied. It plays a role for sure. Now, your question is, does it explain everything, or is there room for additional modifiers, polymorphism, even maybe environmental factors? Never forget, the phenotypic expression of any genetic disease is a result of 3 things: the mutation in the very gene itself, the genetic background, and the environment. If you put somebody with a trend or propensity to obesity in Sahel or Biafra in Africa, I'm not convinced he will become obese, So we have to take this into account. For Fabry disease, important environmental factors have not been identified to the best of my knowledge. I even don't know if they do exist, yes or no. But and the importance of additional all other genes and polymorphism, we may shed a light on it with the coming next generation sequencing, which will allow us, to have a much better knowledge of what's going on. But of course, for this, we need a very strong statistical analysis, which is not currently readily available.